The third case will be presented by Dr. Prasanth and will be moderated by Dr. Sumesh.
Good evening, everybody. This third case is not that straightforward. We hit a few roadblocks before reaching a reasonable conclusion, but suggestions are always welcome as the diagnosis is still in a flux. So the case will be presented by Dr. Prasanth, a first-year DNB graduate, who also played a role in reaching a diagnosis. Over to you, Prasanth.
Good evening to one and all present here. Moving forward with my case presentation, corruption of Formosa. It's a case of a 49-year-old fisherman from Ernakulam. The background of type 2 diabetes mellitus, which is poorly controlled for the past 10 years, and a history of right MCS stroke in 2018. His initial presentation was around 4 months back, and during this course of these 4 months, he presented with multiple symptoms at various hospitals and was admitted and treated at multiple hospitals. 4 months ago, he presented with a high-grade fever with night sweats, left-sided chest pain and swelling. And the relevant findings in the first hospital include high ESR and CRP was recorded, and he was tested positive for anti-dsDNA, SSA and SCL70. With treatment, his symptoms subsided and he was discharged from there. 2 weeks later, he further developed an occipital headache associated with neck pain with intermittent episodes of fever and night sweats. And he was admitted in another hospital. And carotid and temporal artery Doppler there showed circumferential thickening of bilateral temporal arteries, and which proved to be a temporal arteritis with no evidence of halo sign. And his serum AC levels were elevated, which was of 83. An MRI neck done there showed marrow edema involving atlas and axis, which suggestive of possibility of arthropathy. And there he was treated with IV antibiotics, steroids and analgesics. His fever and pain subsided, and he was symptom free for the next 6 weeks and was discharged from there. 6 weeks later, he again developed intermittent episodes of high-grade fever with left-sided chest pain and this time with polyarthralgia. He also subsequently developed left lower limb pain and swelling. He was treated at Hospital 3 with IV meropenem based on a culture and sensitivity report there, and was on IV steroids for around 14 days. A CT test from there showed bilateral basal patchy consolidation with irregular nodular opacities with few central cavitation, which was suggestive of pulmonary emboli, query septic, and he was then referred to our hospital. So on admission at our hospital, he was febrile with a respiratory rate of 20 per minute and saturation 98% room air. Otherwise stable general condition and vitals. He had painful left lower limb movements with no swelling, suggestive of an early arthritis stage, and all other systems within normal limits. Relevant investigations from our hospital include an elevated ESR and CRP with procal of 0.32 and D-dimer elevated at 1516, with chest X-ray showing minimal left-sided lower infiltrate. So here is summarizing. Here is a 14-year-old male patient who is an uncontrolled diabetic with PU of high-grade fever with intermittent episodes of night sweats, with symptoms of polyarthralgia, a history of chest pain and lower chest swelling, headache, and a CT suggestive of a query septic pulmonary emboli with query temporal arteritis with the bone marrow edema involving atlas and axis, with high AC levels and multiple autoantibody positivity.
Okay, we'll stop there. Now, what are the possibilities that we should consider? Like anyone would like to contribute? Are we dealing with infection, or are we dealing with inflammation, or are we dealing with any other disease? What would be the suggestions?
No.
Serum calcium is normal, electrolytes were normal. Pardon, sir? Serum is high.
The sarcoid is the possibility.
Sarcoid is a possibility. Possibility of vasculitis is also there. But he has been having intermittent fever for the past 4 months, receiving multiple antibiotics, subsiding. Again, he is developing fever with other antibody positive. But he's having fever for the past 4 months. In spite of having received steroids, he continues to have fever. Okay, the possibilities that we considered is, here is a patient who has poorly controlled diabetes, having high-grade intermittent fever for the past 4 months. So in our settings, having received multiple antibiotics, in our settings as usual, we should consider infection as the first possibility, maybe some chronic infections which has got partial response to antibiotics that is received. And now in our case, mostly infections like chronic infections like tuberculosis is a possibility. Second, as Sir has mentioned, sarcoidosis is always a possibility as ACE inhibitor levels were very high. But then he has received steroids from multiple places, and sarcoidosis is usually the point against sarcoidosis is that it's usually responsive to steroids. Third possibility we considered is because it's various autoimmune antibodies are positive, definitely some connective tissue disease causing arthritis. But at this point, we can't say which arthritis. It may be some unclassified connective tissue disease, something like evolving lupus or maybe some overlap syndrome. So these are the possibilities that we considered. Next slide. Fungal infections as part of chronic disease, definitely as part of chronic disease like tuberculosis, fungal disease is also a possibility here.
So as Sir has already mentioned, the possibilities we considered were primarily of infective origin, that such as chronic infections like tuberculosis or brucellosis. We also considered the possibility of sarcoidosis in this patient, or an unclassified connective tissue disorder with pulmonary embolism, or an underlying malignancy with a paraneoplastic vasculitis. So considering all these possibilities, we restarted this patient on IV meropenem 1.5 gram 8th hourly and IV steroids based on previous treatment details. We also added IV amikacin, doxycycline, and started on him on low molecular weight heparin. And all cultures were sent, including fungal, and a fiber optic bronchoscopy was done in this patient. And USG abdomen in this patient showed this grade 1 prostatomegaly with a urinary bladder wall thickening, which was otherwise unremarkable. And a 2D echo was done, which was within normal limits. A left lower limb venous Doppler was done to ascertain any origin of emboli, but showed no signs of DVT, but only a mild knee joint effusion. And bronchoscopy was done, and BAL was sent for AFB, CBNAT, fungal stain, culture and sensitivity, and cytology, which all came to be negative. Blood and urine culture sensitivity were sterile. Synovial fluid was aspirated and sent for culture and sensitivity, which was also found to be sterile. And IgM brucella was sent to rule out brucellosis, which was also negative. So patient's inflammatory markers were serially rising, as procal rose to 0.43 and CRP to 127. CNCA, PNCA, and antiphospholipid evaluation were all done, which were all found to be negative. And he has been afebrile for the past few days, but his arthritis progressed to involve more joints with swelling. And he started to develop burning paresthesias initially of the right and then subsequently both lower limbs by the next day. So a nerve conduction study was done, which showed bilateral upper limb and lower limb demyelinating polyneuropathy and a bilateral mild carpal tunnel syndrome. And neurology opinion was sought, which was suggestive of vasculitic polyneuropathy. So this patient was on steroids and IV antibiotics, but his serum inflammatory markers were serially rising. So he was certainly not responding to the treatment. And he has also now progressed to involve the nervous system with demyelinating polyneuropathy, so we needed to move on to an aggressive way of treatment. So we considered the possibility of pulse steroids and IVIG in this patient as a management protocol.
So at this point, we started considering a different possibility of vasculitis leading to progressive arthritis and progressive neuropathy, definitely. And because this neuropathy and arthritis is progressing, we had to treat it aggressively. So far, he has been receiving steroids at a dose of 2 milligram per kg. But since it shows, because his inflammatory markers were rising, it shows that he is not responding to treatment. So definitely, his condition is worsening. Then, so we had to treat his neuropathy aggressively. The other part that was confounding us was his procalcitonin was also slightly rising from 0.3 to 0.7. So there was a possibility of an underlying infection also complicating this disease. So here we have a patient who is having vasculitis leading to causing arthritis and neuropathy, which is progressing, and also a possibility of underlying infection. So what could be the best possible therapy in this patient? The two options before us to arrest this vasculitis is, one is high dose pulse steroid therapy, where give methylprednisolone at a dose of 1 gram per day. The other option is IV immunoglobulin. Now, because we suspected an underlying infection, pulse steroids always has a danger of causing very bad immunosuppression, leading to flare-up of the underlying disease. So the best possible option in this patient was IV immunoglobulin, considering the possibility of an underlying untreated infective process. So to arrest this neuropathy and arthritis, we proceeded with IV immunoglobulin.
So in the following 2 days, but his symptoms worsened to involve bilateral plantar dorsiflexor weakness. An MRI LS spine was done, which showed muscle edema of the gluteal and paraspinal muscles and marrow edema involving the left iliac bone, suggestive of inflammatory myopathy in this patient. PET CT could not be done in this patient due to his uncontrolled blood sugars. His muscle weakness and neuropathy improved after starting him on IVIG, but the left lower limb swelling still persisted. He subsequently developed respiratory distress and saturation fall, necessitating oxygen support, and his imaging was repeated, which was suggestive of multilobar consolidation in this patient. He also subsequently developed a soft tissue swelling around the knee joint with blister formation.
So at this point, though his vasculitis was getting better, the infectious disease process was still persisting and in fact getting worsened. So now we are dealing with a vasculitis with an underlying infection. So we just repeated one blood test to get to the diagnosis of the infection that is confounding this vasculitis. So what is the test that we repeated to get the diagnosis? Any suggestions? Now this is a patient who is uncontrolled diabetes, has exposure to environment, having a vasculitis who has received multiple antibiotics and has received intermittent steroids for the past 4 months. He has received doxycycline when we reached our hospital. And some of the investigation had been mentioned here because of the positive time. Even his lumbar puncture was, his CSF study was done in the other hospitals, including CSF culture. Even that was negative. And all those were done. IgM brucella is negative. But we repeated that one test to get the diagnosis actually. Here's a fisherman, sir. Pardon? CBNAT or the bronchoscopy, we did all the work with CBNAT and all. Go back to previous. Now, looking at this picture of the limb, actually this case is worked up by a rheumatologist and a neurologist, and they helped us a lot. Looking at this picture, rheumatologist, he had suspicion of a certain illness. Looking at this picture of the limb, so he asked us to look for a specific disease again, and because he had presented papers on this disease during his postgraduate days. So one test he asked us to repeat it once more, which may clinch the diagnosis because he had a high degree of suspicion for that illness. Looking at this picture. Second, our postgraduate, Dr. Prasanth, also had a suspicion of the disease. I'll give a clue here. In Capricorn, there was a case of pyrexia of unknown origin, which was presented by Dr. Abrams, sir, where a patient with pyrexia of unknown origin had a similar picture of a lower limb swelling and picture was shown. So after seeing that, after seeing that presentation in Capricorn, even our postgraduate, he had a suspicion of a similar illness. By my suspicion was for something else, because I had seen a similar patient with PO with brucella having a similar monocular arthritis. So I wanted to go behind brucellosis. I wanted to repeat IgM brucella as well as culture for brucella. But then both the postgraduate student and the rheumatologist, they were suspecting the other illness. So we just repeated a blood culture again. Mind you, this is the third time we are repeating the blood culture. And even the first time, second time, the blood culture was repeated in other hospitals which didn't yield any diagnosis. And blood culture was repeated in our hospital. This time we asked the microbiologist to look for unusual organisms, which we did in our hospital. This time also we didn't get the diagnosis. But the third time when we repeated the blood culture, based on the suspicion, we got the diagnosis. And later, the pus, there was a soft tissue on the lower limb that later developed into abscess, and pus culture also confirmed the diagnosis.
So a repeat blood culture and sensitivity was sent, which clinched the diagnosis. With the soft tissue swelling also developed into an abscess, and aspirated pus culture and sensitivity was sent, which confirmed the diagnosis again. So on culture, we obtained a cornflower head appearance on culture, which was suggestive of Burkholderia pseudomyeli infection, heavy growth, suggestive of melioidosis in this patient. So our final diagnosis was this case of disseminated melioidosis, which is presenting as fever of unknown origin with multilobar consolidation, soft tissue abscess in the background of uncontrolled diabetes mellitus, with an underlying unclassified connective tissue disorder with polyarthritis, vasculitic neuropathy, and multiple autoantibody positivity. So he was started on injection ceftazidime 2 gram IV 6 hourly, along with continued on meropenem, and tap cotrimoxazole was also added. His symptoms significantly improved, but due to their financial constraints, they wish to continue the treatment at Government Medical College Kottayam, and is currently on follow-up. So coming to a small discussion part. Melioidosis, Burkholderia pseudomyeli is the causative agent. It's found in soil and water, and humans and animals are commonly infected by inoculation, inhalation, or ingestion. And it causes a wide spectrum of conditions ranging from asymptomatic infections to abscesses, pneumonia, and disseminated diseases in individuals. So it is a significant cause of fatal community-acquired pneumonia and septicemia in endemic regions, and acute pulmonary is the most common diagnosed form of infection. It also causes chronic pulmonary infections with systemic manifestations that can mimic tuberculosis in patients. So treatment is mainly divided into 2 stages: an intensive 2-week phase therapy with ceftazidime or a carbapenem, followed by at least 12 weeks of oral cotrimoxazole to eradicate and prevent relapse, which is common in this condition. Also, I would also like to convey my sincere regards to Dr. Emil sir, our consultant rheumatologist, Dr. Soumya ma'am, our consultant neurologist, Samit sir, our consultant pulmonologist, and Dr. Joyson sir, our consultant physician, and also Dr. Ranjini ma'am, our microbiologist. Also, I would like to personally wish to convey my regards to Sumesh sir for his guidance and support throughout this course of presentation. Thank you.
Thank you. Why we named this corruption of Formosa is because this disease, when it was initially reported in the early 20th century, it was taken. It was known by a fictional name of Tapanoli fever or black corruption Formosa. It was used as a biological terrorism weapon in one of the Sherlock Holmes novels, The Dying Detective. So that's where we took this name. And this time we are quite lucky because blood culture 3rd time revealed the diagnosis, and definitely a strong clinical suspicion. And with a good clinical history will definitely help us to get the diagnosis. And many times we'll have to repeat some of the investigations to get the diagnosis. Thank you everybody for patient listening. Abraham sir, do you have any points to add?
Very strong point in favor of melioidosis. We don't look for that, but I was more interested in the history. That's why I kept on asking the history. Was there any exposure to a condition where you are prone to develop melioidosis? Because fishermen usually, actually that's where I wanted the history. Was he involved in fishing in the sea or the lakes? All that is important, because person exposed to seawater, very unlikely for him to get melioidosis. But unlike a person who works around the canals and lakes, is very much prone. Because in olden days, the older textbooks of Harrison mentions that this is a disease that is mainly afflicts well diggers. In fact, the case where which I presented, which you mentioned, the clue I got was from that. Actually, that exposure to he was a barefooted person getting exposed to mud. He used to work in the fields, so that's why he kept on. It was there in the back of the mind, but he kept saying it was a fisherman. So in my list, it went down. But it was a very good presentation. And any case where we have multiple opacities in the lung, necrotizing pneumonia, melioidosis should come first.
That's exactly the point I wanted to ask Dr. Sunny Oratil. Looking at that X-ray and CT scan, did the bell ring anywhere? This is a patient who had multi-system involvement. And from the very beginning, that D dimer was very high, 1550. Subsequent X-ray showed typical features, very florid features. Does that strike any,
Sir, we cannot say melioidosis even when there is such florid presentations in the chest X-ray, unless there is some chronicity. And of course, when we exclude other possibilities, then we should go for again repeat history taking and all. Then only we will be able to make a diagnosis clinically. Of course, by excluding the other things and going for repeat investigations, we may reach the diagnosis. But this is not very common. Actually, I was also surprised to hear the diagnosis as melioidosis, and the clue I got once Sumesh told that this was present by Dr. Dijan earlier. I haven't seen such cases of melioidosis in pulmonary practices. Of course, it is said in the literature, but we are not seeing such cases.
Thank you, everybody. This was a team effort for reaching this conclusion. Actually, whenever we are in a spot of bother, we usually take the help of many colleagues, both outside our department and within our department. And many times, when we are in a spot of bother, we usually take help of senior physicians, Dr. Abraham George, Dr. Joyce, and Dr. Sunu, and even Dr. Sister Romeo, and to come to a conclusion in some other mystifying diseases. And in very, very challenging cases, we have our redoubtable Dr. Paul Putran sir to always guide us. Thank you. For the association matters, I hand over the podium to Dr. Abraham George, and thank you, Prasanth, for a very lucid presentation.
Thank you, students, for the nice presentation, and thank you, Dr. Romeo, Dr. Putran sir, and Dr. Sumesh, for presiding over the cases.